Hi everyone, my name's Eileen Regan. I'm the CCO of Examen, and it's my pleasure to welcome you this evening to the 8th webinar in our 2021 Male Fertility series. So the webinars take place on a monthly basis, and we're joined by experts in the field of male fertility and treatment and therapies. And the event's open to all. So we have a wide range of participants joining us, from academics, HCPs, urologists, embryologists, fertility specialists, as well as the men, couples and individuals who are on their own fertility journey. So the views presented in this webinar are the views of our speakers and not necessarily the views of our company Examen. You're all very welcome to join us today. So let me first introduce you to our speakers. So we're joined by Professor Peter Humaidan, a specialist in reproductive endocrinology and professor at the Fertility Clinic, Skive Regional Hospital, Aarhus University, Denmark, and Honorary Professor at Odense University in Denmark. So Peter is joining us today to discuss the links between lifestyle and sperm DNA fragmentation in his new book, Super Sperm. And the book covers a historical view of male fertility, psychological aspects of male infertility, and the importance of DNA fragmentation. Importantly, the book also covers lifestyle modifications which are known to reduce DNA fragmentation as well. Our chair, Professor Sheena Lewis, is the founder and CEO of Examen and an honorary professor at Queen's University, Belfast, where for the past 25 years, she's dedicated her research into novel testing for male infertility. She's currently executive member of the Association of Reproductive and Clinical Scientists and chair of its Scientific Advisory Committee. She's published over 100 full papers, as well as numerous book chapters and reviews. She's been past chair of the British Andrology Society, UK National Representative and chair of the Andrology Special Interest Group of ESHRA, an executive member of the British Fertility Society, and was a founding member and vice chair of the Irish Fertility Society. Professor Lewis's research has led to the formation of the company Examen, where it markets its exact range of male fertility tests powered by the Sperm Comet technology, which is now the market leader for sperm DNA damage testing in the UK and Ireland. And also joining us tonight as our co-chair, Dr. Leslie Haddock, who completed a PhD in molecular diagnostics at Queen's University in Belfast before joining Examen in 2019 as R&D manager, where she leads an extensive research and development program for the company, investing new and novel techniques in male fertility. Leslie's work has focused on the development of novel diagnostic assays for male fertility, and she has collaborated on numerous publications and book chapters, including her most recent publication titled Sperm DNA Fragmentation is a Novel Biomarker for Early Pregnancy Loss. So thank you all to our speakers and our chairs today. So just before I hand over, I just wanted to run through some housekeeping. So we'll start the session with a short introduction by Professor Lewis of Examen and of the topic for tonight. Then we'll hand over to Professor Humaidan for the main event. And then at the end, we'll have about 5 to 10, 15 minutes, depending on time, for a Q&A with our speaker and with Dr. Haddock. So please do pose your questions throughout the talks using the Q&A panel. We would use the chat function just for any technical issues or if you need to contact us directly. But please do use the Q&A panel for your questions. And then you'll also have the opportunity to rate questions. And then Dr. Haddock will then share the questions through during the Q&A session. So any technical issues, use the chat and we'll do our very best to help you. The attendees will be muted throughout and videos enabled for our speakers only. And all the events in the series are recorded and made available on the events page of the examenlab.com website following each session, so you can watch any events you've missed. And please allow up to 24 hours for the recording to be available. Furthermore, 1 CPD point will be awarded for attendees for the event, and a certificate again will be circulated after the event. So at the end of the session, you'll be invited to rate. All your feedback is very welcome and helps us improve these events and suggestions for future events. So I encourage you to do that. So thank you for listening. Please let me now hand over to our chair, Professor Sheena Lewis, to start the session.
Good evening, everyone. It's a pleasure to be here yet again. We're almost at Christmas and we just have one more webinar after this before Santa comes to visit. But tonight we have a very important topic to discuss. And as you know, our aim is to help more men become dads. The mission of our company is to raise the awareness of male infertility, because as we know, there's so few people who know just how important that is. And you also know that over the last 40 years, the focus has been so much on women, leaving men emasculated and without the knowledge that they need. So we want to provide them with knowledge, advanced testing, and to demonstrate that optimizing sperm health will improve fertility outcomes. Of course, the semen analysis is the most important thing to start with. You need to find out if the man has sperm, you need to know if they're swimming, and you need to know if they've got good structures. But that's not really quite enough. What we need to do as well is to look at DNA, because it's the DNA, of course, which is going to make the child look and act like their dad. Just a little bit about Examen for those of you who haven't joined us before. The company's been running for about 11 years now. It was founded as a university spin-out due to public demand, because we published some papers in human reproduction and also in fertility and sterility. And people started emailing me and saying, can we have the test? Now, at this stage, of course, I was a humble professor with no idea at all that we would be starting a company. But because of the need, we did start it. And over the last decade, we have rebranded, we have expanded, we have brought on new staff, and we have got very strict regulations now, so that we've got an ISO 13485, which is an indication of the quality of our test. The tests are based on years of academic, non-commercial research. And all the work that we did in the early days was really to see if the DNA test stood up to various assaults and hazards that we put towards it. And we found that no matter what we did, DNA gave us a good result and a very reliable and reproducible result. And so that's why we focused on this rather than any other test to supplement the semen analysis. Why choose Examen rather than another test? Well, we would suggest because it's the only test on the market that actually reports the DNA damage per sperm and compares it with fertile thresholds. We can detect single and double strand breaks. We're now being used by 80% of the leading UK clinics in the private sector. And people say we've got excellent customer service, but for those of you who are talking or who are listening to me tonight, if you haven't used us, well, we would be delighted if you did, and then you can see if we stand up to the reputation that we have. So what can DNA testing do for men? Well, the most important thing, it will be able to they can take back their control of their fertility. At the moment, men just don't know what is happening. They're not given any information, and they're really left in the dark. And that's one of the reasons why they become disengaged and disenfranchised and don't want to do any more fertility treatment. Sometimes it's a bit of a struggle between the two partners. But if we can make them become equal players in the role of becoming parents, and they get a chance to take control of their sperm motility and to improve it, then we find that they're much more likely to remain engaged in their treatment. For many years, there was no international guideline which said anything about sperm DNA testing, and now there are many, and we're absolutely delighted about that. The European Association of Urology has said that more complex testing than a semen analysis is required, especially for those who have unexplained male infertility or those who have recurrent pregnancy loss. ESHRA has said that we ought to be checking men out, and that's a big step away from what they'd said in the past, because they always thought it was purely a female problem, but now we're saying that it's a male problem. And at the moment, I'm co-authoring the recurrent pregnancy loss guidelines, and they'll be coming out in 2022, and they'll be even stronger than what we have said in 2017. And then the American Society of Reproductive Medicine, which has always been hesitant to support DNA testing, has joined with the American Urology Society and said things which we think are absolutely wonderful. Because what they've said is, in couples who have failed ART or recurrent pregnancy loss, the male partner should be evaluated by a male reproductive expert. Now, you may think that's obvious, but actually it's not often done. It's very seldom that a man has a clinical history or a clinical examination. And now, of course, they're also saying that consideration ought to be given to DNA testing as well. And then, if that weren't enough to happen in the last year, the WHO manual, which has just come out a few months ago, has now included sperm DNA fragmentation in its extended examination. In the previous manual, it was there as a research tool, but now, if I can just quote, it says, clinically, there is a growing awareness that chromosomal anomalies and gene mutations underline a diverse spectrum of male infertility that underlies many of the anomalies seen in a semen analysis. So what they're saying is that we should be doing DNA testing as well. Now, we know that lifestyle choices can be sperm enemies. I don't want to steal the thunder of our speaker this evening, but he and I are very much in agreement with this. Professor Humaidan has got an amazing research profile. He is a clinician, but as well as a clinician, he's the associate editor of RBMO. His total number of publications is 353. He's got a fantastic H-index, which is an indication of the number of people who cite his papers, who read his papers, who download his papers. And he has research in many areas of male and female infertility. So there's no better man to be speaking to us on this occasion than Professor Humaidan. So I'm going to hand over the floor to him now. He's just published a book called Super Sperm, and he's going to tell us all about it. Professor Humaidan, you are most welcome with us.
Yes, Sheena, thank you very much. I'll just try to get connected now. So here we are. Dear friends and colleagues, I hope you can see my screen and that you can hear my voice also. It's a great pleasure for me to be with you tonight. I'm speaking out of dark November, Denmark. And usually in Denmark, we could say we have September, October, and then we have November, 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 November. So rainy and dark. It used to be snow and frost, very little of this now. Now, this evening, I'm going to talk about the results of my book, and the book as in terms of how do we, as Sheena said, how do we actually get these guys, these males on board also, so that they feel equal in the treatment. And this is what every man would love to have, the super sperm. But what is super? Well, super is an adjective that describes something as of the highest power or an extreme degree or as excellent. We know this from super quality petrol, which brings us very, very far. Now, let's just look into some infertility facts as of 2021. 186 million infertile people globally. It's a vast number. It's just increasing. 10% of all couples. 50%, this is what we usually say, but I'm sure it's actually could be even more, are cases caused by male factor. We now have approximately 8 million children born from some kind of ART, and approximately 50% of those are conceived by ICSI, indicating a male factor. In Denmark, which is probably the highest number aligned with more or less what we see in Israel, 10% of the Danish birth cohort derives from ART, also because we have a high degree of reimbursement in our social security system. Now, some more facts. Well, 20% of Danish males have a low sperm count, according to WHO. 25% of Danish males will never father a child. And I think what is even more interesting is that childless males actually feel more isolated and depressed than females in the same situation. Now, why did I write this book, which until now is only in Danish? Well, the whole idea was to remove the taboo concerning or surrounding sperm. We need to bring sperms into focus in 2021. Also because the male role in society is changing. We see these younger fathers who are much more equal in their marriages, who take care of the kids also. And they want themselves also to be much more active in lifestyle if they can do anything to change the chances of conception. So the whole idea of this book is to show that We as males should take responsibility for our own bodies, and by doing so, we are also taking responsibility for our offspring. And the most important thing is also that we've always been told that the biological clock is ticking for our ladies from the age of 35 and onwards. But actually, we see more or less the same thing for males, beginning approximately at the end of 30s and then just increasing more and more in terms not of quantity, but of DNA quality. So what I suggest is a fatherhood preparation for 3 months for all these young couples who try to conceive, in which the father considers his lifestyle in order to be able to deliver sperm of the highest, not quantity, but quality. So when we talk about semen, and this I think is general in the whole world and also for Europe, obviously, semen is regarded with a lot of guilt and shame, because semen is usually something we see after sex or during masturbation. And here you see this sneaky sperm, which can find its way in through all small corridors. It's something that I think it looks dangerous. In contrast, you see these wonderful eggs, which we have nearly on a weekly basis, but we also see them for our Easter parties. And I think for everyone sitting at an Easter lunch, it's okay to discuss eggs. But if your neighbor started discussing sperms and his sperm quality, I think this would be considered an offense until now. Now, why do we have this impression? Why do we have this taboo concerning semen? Well, it's all the way back from the first book of Moses. Now, in Denmark, masturbation is called onani. And where does this term come from? It comes from Onan. Onan was a person from the first book of Moses who was asked by God to impregnate his wife, but he refused to do so, and instead he wasted his semen on the ground, and for this he was punished with death. So death sentence for kind of masturbation, all the way from the Bible. Now, generally spoken, we could say that males are usually on the sideline when we talk about fertility, because fertility historically belongs to the female. This is just one example of a Danish gynecologist. A woman is considered responsible when she considers her inner organs, ovaries, womb and vagina, and her functions and wife and mother to be. This is 1892. So fatherhood has always belonged to the male. So this means that infertility actually belongs to the female. And this is what we see in many parts of Europe, but definitely also in many parts of the world, that you would have fathers with extremely poor semen quality, but it's not recognized as a problem for him. In contrast, it's a problem for the mother to be. So when we talk about infertility, the eyes are always very firmly fixed on the woman, and the man has been reduced to a semen blob, something very, very objective. And the worst problem is that males do not regard their semen as something that they need to protect. When we talk about spermatogenesis, it's a highly complicated process. We need more than 2,000 genes to produce just one sperm. And look at this, approximately 1,000 sperms are produced in the testis per second. And finally, up to 96% of those sperms are completely abnormal. So here you see 4 young guys. They are involved in a party. They just stepped outside. You can see they're smoking, they're drinking. And what I can tell you, they're not talking about infertility. They're not talking about sperms, because we males do not like to talk about infertility and sperm, because somehow it's still involved in our potency. So these guys are having the usual talk about some of the ladies who are inside the room. Now, when we talk about males with a reduced sperm count, we published this paper years ago in which we were investigating 210 males who more or less had ICSI quality. And what you can see is that nearly 1/3 reported a negative impact on their masculine self-image. 62% had a sense of a lack of communication with the staff regarding their challenges with a reduced semen account. So they felt that although the problem was theirs, the majority of the communication was directed towards their female partner. Again, this was 63% who had this feeling. And finally, 72% of these males lacked information about male infertility. And the most common question was always, but can I do anything myself, and what can I do? And this is also one of the reasons why I was very fascinated about this area and I wanted to write the book. So let's just look into the current state of semen quality. Well, this is the Semen Analysis 2021, and I put in brackets 1916 because not a lot has changed since, or more than 100 years ago. We look into how many, what do they look like, and how do they swim. This is now the Semen Analysis of 2021, the concentration, the percentage of motile sperms, the motility grading, the morphology, that is, how do they look? So we should have at least 4% normal, and then the total motile sperm count. But does this actually cannot tell us anything about quality? These are all quantitative parameters. I usually say this is just looking at a name sign in which it says it stated the name of the person and his occupation, but it doesn't tell you anything about the inner things about this person, his psychology and his intellect. It's the same with sperms. You just get a very peripheral idea of what do we have when we look into the concentration, the quantity. And if we go into WHO, we know that the current lower cutoff of a normal semen count is 15 million per mil, which is actually extremely low if we look into time to pregnancy. Because according to an old Danish study performed 15 years ago, for time to pregnancy within 1 year, you actually need more than or equal to 40 million per mil. And this also means that a lot of young guys who are around 20 million per mil will be told by their GP that they have a completely normal semen count. Although, well, it's the truth according to WHO, but it doesn't tell them anything about time to pregnancy, which is actually the most important parameter. So what about the Danish male who's got 2 kids? You can see he's got around an average of 80 million sperms per mil, so significantly higher than the time to pregnancy concentration, and also significantly higher as compared to the WHO classification. So this is the paper which really created a lot of discussion. Nearly 40 or more than 40,000 males, a 40-year observational period in which you can see that there was a decline in the sperm concentration by more than 50% over those 40 years. And these patients came out of, or not patients, but these participants came out of North America, Europe, US, Australia, and New Zealand. And generally spoken, you can say that there is a 1 to 2% decline in sperm count per year until now. So this is now in, you can say, the Western countries. So what about China? What does it look like there? Well, again, a very large sample here, 30,000, and now from 2001 to 2015, and we see more or less the same problem here. You see the mean sperm count, 68 million in 2001, and if we move up to 2011 to 2015, the mean has reduced to 47 million per mil. And it's a huge sample size, so I think we can definitely rely on this, and obviously this is highly significant. So not only in Western countries do we see this significant decline in the quantity, but also in Asia. So what about Denmark? And you all remember that William Shakespeare wrote something rotten is rotten in the state of Denmark. And again, we see this sneaky sperm. And well, something was rotten in the state of Denmark. The problem is, what can we do about this? Is it enough just to have a mint? And as you know, extensive studies have been performed in Denmark, and we've been very lucky to have studies which have been going on for many years, and these are now conscripts. And you can see this is a time period from 96 to 2016, 300 conscripts a year, and you see the year here, the years here, and you see the percentage of quality. Now, what this study showed, published 2018, was that 16% had less than the WHO criteria. 35% had low quality or intermediate quality based on combined parameters, and actually only 22% had more than 80 million per mil. Remember, this was the number that you saw generally in mean of males who had more than or equal to 2 kids. So very worrying facts. Now, usually when you talk about semen, you would hear, even from professionals, your semen quality is so and so, although what they're talking about is definitely not quality, it's quantity, because in reality, quality is a completely different marker. And how do we actually measure quality? Well, to just make this very simple, here you see the double helix of the DNA molecule, and you have these DNA sleepers, and you have also here you see the railway with the railway sleepers, and you can say, said in a very popular way, that when you have DNA breaks, what you accomplish here is the same as what you accomplish if you have breaks in your railway sleepers. You're going to have a derailment, and here this is the derailment of the train. But for the sperm DNA, you're going to have derailment of the fertilization and the cleavage process, and also of the early pregnancy. And the only way we can know whether we have any problems in DNA damage is to dig one piece deeper into the ground with the spade, as done here. And obviously this is by looking into sperm DNA fragmentation. Now, DNA is damaged by oxidative stress, among others. And the DNA damage occurs more than 100 times a day in a human cell. But the good thing is obviously that somatic cells are capable of restoring DNA damage. And if they don't do so, they're very likely to die within a few hours, or they could also mutate and become cancer cells. And they could also mutate, and the patient would then achieve other diseases. So this is the pattern of the somatic cell. So what about the DNA, the sperm cell? Well, it cannot repair DNA damage. And this is why nature tightly packed DNA to protect the sperm from DNA damage. The important thing about DNA damage is it cannot be visualized on the surface of the sperm. Again, you cannot see this from the name sign. You need to dig a bit deeper. And another important factor is that sperms with DNA damage are motile, so they move around. They can be used for ICSI. They can still fertilize the egg, either naturally or even during assisted reproductive technology. So what we can say about the sperm and DNA fragmentation is that actually the sperm will function as the canary in the coal mine, or you could also say as the whistleblower, because as sperm is not capable of restoring DNA damage, but body cells are. If we look into the sperm, we will get quite a nice pattern of the whole body in terms of health. Now, quite recently, you can see this was March, we published this paper with Sandra Steves and Sheena Lewis and others on sperm DNA fragmentation testing, and we came up with summary evidence and clinical practice recommendations. So how do we measure DNA damage? Well, obviously, or DNA or SDF, sperm DNA fragmentation, as it's called also. Well, there are different methods. There's the SCASA, there is the Scd, the tunnel, and the COMET assay as provided by Sheena. The SCASA, which was initially suggested and also extensively studied by Donna Evenson, who is with us tonight. And how often do we find an increase in sperm DNA fragmentation? This is now the Scd test, and this is from Esteves et al. And you can see in his unit, looking into 1,500 infertile men, he found that more than half of these patients had an index of 20% or greater, which is the cutoff for where we see that problems in terms of natural conception, but also problems when these couples go into ART start to occur. So we look into different thresholds. You see some of the most common used methods here for sperm DNA fragmentation testing. And obviously, the abstinence time plays a significant role. Now, until now, the abstinence time, which has been suggested for these tests, is 2 to 5 days. But I can tell you, even our unit, we started reducing the abstinence time because we know that the lower the abstinence time, the higher the chance of getting high quality or less DNA fragmentation. And when we talk about thresholds for these 4 tests in terms of the percentage of sperms damaged, having DNA damage, you can see that more than 15 to 25% increases the risk of male infertility. And if we do ART, more than 20 to 35% will decrease the chance of pregnancy and increase the risk of early pregnancy loss. Now, this was a paper which we did several years ago, and we actually collaborated with Don Evenson on this paper. This was one of the initial papers looking into what happens if we use DNA fragmented sperms in our daily work in infertile couples. And this is the SCASA method. And as you can see, we were looking into IUI patients with less than 30% DNA fragmentation or above 30% DNA fragmentation. And you look into the delivery rate, you can see that having a DFI above 30% significantly reduced the delivery rate. And we would say, well, then definitely you should never do an IUI in this kind of patients. Remember, these patients had a complete normal sperm quantity. So even today, a lot of patients are undergoing a lot of IUI cycles, and their chances of conception are at this range because they never had a DNA fragmentation testing. So we went further in this early study and wanted to compare patients with high DNA fragmentation according to SCASA who performed IVF and compare those to patients in whom we did ICSI with high DFI above 30%. And here you can see actually significantly better results in terms of delivery rate if a person with a high DFI underwent ICSI instead of IVF. Now, since this time and all these discussions about the validity or not of DNA damage testing, this was one of the first meta-analysis coming up. And here we're talking about odds ratio. And you can see whatever study we came out with, nearly all of them suggest that the odds ratio points against a negative impact on clinical pregnancy rates in terms of DNA fragmentation. And a very recent meta-analysis now, a larger study here, and here you see the compiled data of IVF and ICSI in terms of implantation, pregnancy rate, and live birth rate. And here we talk about risk ratio, and risk ratio less than 1 indicates a greater risk of a negative outcome. And if we look into these compiled IVF and ICSI data, we see exactly here significantly lower implantation, significantly lower pregnancy rates, and a borderline lower live birth rate. If we then subdivide into IVF only and ICSI, we now see significantly lower implantation, pregnancy, and live birth rate for all IVF groups. In contrast, we now have a trend, but it's not significant. We have a trend for lower implantation, lower pregnancy rate, and lower live birth rate in the ICSI group. So what actually induces DNA damage? Well, age is an important factor. This is the oldest reported father. He was 96 years old when he had this child. He fathered 2 children and he wanted more, according to what he was stating at this time, but he passed away at the age of 104 years. So is this a good thing? Well, according to Don's recent paper, an extreme amount of patients, more than 25,000 males in whom DNA fragmentation using the SCASA test was done, you can see what happens from the age of 40 to 50, a significant increase in DNA damage just by the biological clock. So there would be a doubling of males from 20 to 40% during this time span in whom the DNA, the DFI, was more than 25%. So a doubling of males with an increased DFI just due to the biological clock. And this is a huge sample size. At the same time, we had the other group, and this is from also from US, also thousands of patients, and we see exactly more or less the same thing. And actually, by each age group, there is a significant increase. Again, it seems to start around mid-30s, and then it goes up and highly significant from year category to year category. So what we have to remember is that more than 70%, 75% of germline mutations are of paternal origin, and that their total number actually increases with the age of the father at the time of conception. And this was very nicely shown in this Nature publication by Kohn. This is now the entire genome sequencing of a number of fathers and their offspring in Iceland. Here you see the age of the father at the time of conception of the child, and here you see the number of de novo mutations in the child. And obviously, the older the father at age of conception, the more the mutations in the child. So why does this matter? Well, the older the father, the higher the risks actually of the offspring, and this has been studied intensively, and we see that there is a significantly higher risk of child cancer and leukemia in the kids of aging fathers, also metabolic disease, neuropsychiatric diseases like bipolar disease, schizophrenia, and autism. So what can we do about this? Well, obviously you can't do anything about your biological aging, but what you can do something about is your lifestyle, because we know that the biological clock is there ticking. We cannot do anything about it. We also know, and I'm going to show you which factors actually play a significant role. We know that lifestyle definitely has an impact on DNA damage. And if we cannot do anything about the biological clock, we can definitely do something about this very lazy, obese person lying in the sofa and wanting another child with maybe his second wife. So which are actually the worst, let's say, enemies of DNA? Well, it's nicotine, so it's cigarettes, e-cigarettes, chewing tobacco and snuff, but also cannabis. But apart from this, we have a row of factors which play a role. So in terms of DNA damage, it's alcohol, it's caffeine, it's the type of diet, specifically the Western diet with a lot of meat and very little vegetables, very little fish, overweight, sedentary life, heat in terms of very tight pants, and also the idea of always carrying your mobile in your pocket and the computer on your lap. For alcohol, we know that if you consume more than 20 drinks a week, you are prone to have a significant negative impact on the concentration and the motility. No one actually looked a lot into DNA damage, but we also know that if you have more than, you start seeing these negative impacts already in terms of more than 5 drinks a week. For caffeine, more than 2 cups of coffee a day seems also to have a negative impact on the DNA breaks. And diet, I'm going to show you, plays a significant role. Overweight, yes. Why? Well, you could say an obese body will have more antioxidants in it, and also the overweight in the fatty tissue. A lot of the testosterone is converted into estrogens, which actually obviously will have a negative impact on the spermatogenesis. And also the weight will induce more heat around the testicles, which will have a negative impact on DNA. So the same for sedentary life. Sitting there with your legs very tight heats up the testes and will induce DNA breaks. And so the same with the tight pants. And for mobiles and the computers, well, these are obviously the this is now the electromagnetic radiation. We need more and larger studies, but there are studies showing a negative impact on DNA damage in terms of mobile pocket carriers, especially if you are, obviously, if you have them in your trouser pocket, so you should wear them somewhere else. Sorry. So again, you see this typical guy who is early 40s and he's trying to have his second child. He's obese. He has a very poor lifestyle. But I think we just have to scratch a little bit and say, well, if he was some 1,000 years back in the Stone Age, nature will say, well, how is this person going to be able to provide food for his kids? He's not going to be it. So let's say in a very popular way, you could say nature will draw down on the spermatogenesis and favor other things for this person just to be able to survive his obese life. So a very unhealthy life obviously will have a negative impact on fatherhood. So you could say, so what about the environment, Peter? The semen quantity and quality, I totally agree with you. We are just surrounded by a toxic cocktail of pesticides, phthalates, bisphenol in our plastics, parabens, and mercury. The problem is we as individuals cannot do a lot about this. We need to go to our politicians and they're trying to do changes, but obviously there's a lot of finance involved in this. So lifestyle change is much easier. It just reminds me like a speedboat, because this is what you do yourself in comparison with one of these oil tankers. It takes you days and days to change the direction. With a speedboat, you can go very speedy. And just like to change also, use this wording, ask not what your country can do for you, ask what you can do for your country. This was what JFK was saying, but I would say ask what you can do for your own body instead of asking what your country can do for your body. So in the book, we describe what we call as a fatherhood preparation, which is of a duration of 3 months. And some of you who are not into the specialty would say, 3 months? Why 3 months? Well, this is the duration. This is the time it takes to produce a new sperm. In reality, it's 64 days plus minus 8 days. So just to keep it simple, we say 3 days. So we are very lucky being males that we produce new sperms every 3 months. Remember, our females, they carry around the eggs that they had in their fetal position, so they don't produce any new eggs. So we can actually have an impact on the quality of our sperms. So what we need to do, obviously, is quit smoking completely, no more than 5 drinks weekly, a maximum of 2 cups of caffeine daily, and exercise 30 minutes daily of moderate intensity. And then we should focus on less meat. So a maximum of 500 grams of processed meat a week, more fish, at least 300 grams a week, and more poultry. And you could say, where did you get all this from? Well, the majority of these facts are actually just the health recommendation from the Health Society in Denmark for a healthy life to avoid cardiovascular disease, diabetes, etc. The only thing which is more strict here is the drinking when we talk about fatherhood, because if we talk about general health, the recommendation is up to 14 drinks a week. But for males, our recommendation is no more than 5 drinks a week during the fatherhood preparation. We should also have more vegetables because they contain antioxidants. If you are obese, you should obviously lose weight to have a more healthier body and also to reduce the temperature around your testicles. Mobile out of the pocket and computer away from the lab. Now, this is a retrospective analysis, quite large, nearly 3,000 Danish males who reported how often on average they consumed specified amounts of a total of 136 food items during the 3 months before enrollment. So yes, it's a retrospective analysis, but it's still interesting because these authors were describing 4 dietary patterns: Western, which is like Western lifestyle, fatty food, a lot of caffeine, beer, alcohol, etc. Prudent, which is more like in line with what we see the recommendations by our health authorities for a healthy life. Open sandwich, which is a traditional Danish dietary pattern. And finally, the vegetarian diet. And then these authors were looking into the sperm count. And what they found was that the highest sperm count was actually seen in the prudent diet. So aligned with the recommendations by Danish health authorities, followed by the vegetarian diet, but the lowest sperm count was seen in the Western dietary pattern. Now, recently, we wanted to look into the combined effects of lifestyle intervention and antioxidant therapy on sperm DNA fragmentation and oxidative stress in semen in IVF patients. And again, this is a pilot study. We needed to screen approximately. So what we did was that we looked into our files of patients who were undergoing IVF treatment, and we were able to find a number of patients who had failed IVF attempts. So from these patients, we did DFI in a series of patients, and we had then 31 males with at least 2 failed IVF attempts who had a DFI, so DNA fragmentation according to the Scd method, of more than 15%. Now, all these males had to fill in a personalized questionnaire, including 68 lifestyle-related questions. And then they underwent an individualized lifestyle change program during a 3-month period prior to the next IVF treatment. And you can see the antioxidant therapy was 1 multivitamin once a daily, and then omega-3 1 gram daily, and Q10 100 milligram daily. This was the antioxidant therapy. So what were the results of this? Well, as you can see, the majority of participants actually achieved a decrease in their DFI. And the ones who achieved the highest decrease were the ones who had the highest DFI also. So in this group, we had males with a DFI of 40% of their sperms with DNA fragmentation, who after 3 months intervention ended up with 22%. The mean decrease, as you can see, was 7.2%. And you could say, well, that's enough. That's not enough. Well, it's quite enough, because if you want to be lower than 20, and you include a lot of males who are around 30 or 25, 22, the majority of these males will have more or less a normal DFI. And some of these males will also be able to achieve pregnancy themselves. And actually, during the study period, 2 of these 31 males achieved normal conception and live birth just by lifestyle intervention. But I think this is important. We did not see any differences in sperm parameters. And this is also our impression from earlier studies we did. And this is what I always tell these males: don't expect any changes to the concentration and the motility, because this is not usually when we see, at least not after the initial 3 months. Another important factor was we did not see any difference in the oxidative stress parameters when using the Oxis test. So I think some of you heard the excellent lecture by John Eichen, and this is one of his latest papers asking the question, should we be measuring DNA damage in human spermatozoa, putting new light on an old question? And obviously, the question is quite obvious. The answer is quite obvious from his side and from my side also. And I think for John Eichen, he's always saying, well, obviously, you are going to achieve a higher chance of a live birth after your assisted reproductive technology treatment. But the most important thing is that the chance of having a child, your offspring, with a better long-term health is significantly higher. So of course we should do so. Just to show you that instead of just considering the male as a semen blob, this is what we need to do, and we already do this in our units. We have to look into a lot of testing. Look, has he got a varicocele? What is the reason for is this unexplained, so-called unexplained? Because obviously there's usually an explanation. Is this recurrent pregnancy loss? Do we need to come up with some fertility counsel? Is this a person who needs sperm freezing? Obviously, we would need to know that the sperm DNA quality is perfect. So again, this is a flow diagram showing you how complicated actually the investigation of the good let's say, the good investigation of males has come, because if you do sperm DNA fragmentation testing and you end up with abnormal results, well, obviously the patients have to change their lifestyle. They should also, it seems that there will be benefit from oral antioxidant intake, but we also need to treat the underlying pathology. If we find a varicocele, we need to repair this. This is gonna reduce significantly the DNA damage. If we have genital tract infections and leukocytospermia, we also need to treat this with antibiotics. For assisted reproductive technology, well, in males who have lifestyle resistant high DFI, well, we should consider ICSI and other sperm selection techniques. And in some cases with very high DFI, and this is what we're already doing now, so in males who underwent a 3-month lifestyle intervention and still have high DFI above 30%, we now use testicular sperms instead of ejaculate sperms, because it's been proven in meta-analysis also by Sandra Stives that the DNA fragmentation rate in testicular sperm is considerably, significantly lower as compared that of the ejaculate. So the infertile male as of 2021, well, has changed from just a semen sample into a full body person. And I think what is very important today is to treat our males as equal partners in infertility treatment. And we need to put the male into center. And we also need to be sure that he has done his best job to deliver what we could call a super sperm in terms of the best quantity. And if we go back to Renoir until now, you see this couple here. I'm sure this lady is telling this person, come on, you're now 35 years of age. We should definitely embark on fertility treatment, or at least start getting a kid, because your biological clock is ticking and so is mine. And here, these 3 persons, well, this lady is telling her husband, look at you, you're smoking, you're drinking, your friend has started a fatherhood preparation regime, you should do the same. So thank you very much.
Thanks, Peter, for that really informative and interesting talk. We have a few questions starting to come through now. I think we'll begin with, do you recommend Impril for high DNA fragmentation? And this is in reference to a 58% SCASA result.
Well, what I can say, we usually recommend more. Until now, we do not recommend any other medications just than antioxidant treatment and lifestyle intervention. So if we don't see any decrease in DFI, what we do is, as I was telling you, in very high DFI, we would do testicular biopsies, because we know that the chance of having better quality in terms of fewer DNA breaks is higher. So until now, we did not use any specific medication. But what I just also wanted to just ask you all to bear in mind is the increasing use of antidepressants, which is something that a lot of my colleagues are not aware of, that this per se will increase the DNA damage in sperms even after just 4 weeks. It's been shown in studies published in Fertility that before the start of using these preparations, these antidepressants, there would be like 10% of males who would have more than 30% DNA fragmentation. After 4 weeks, 50% of males are above 30%, which is a real problem. And I think we are nowadays, at least in Europe and also US, treating a lot of ladies because, and we do not consider that their males are actually on antidepressants, and it could be for ADHD treatment also. A lot of males are taking this kind of SSRI drugs, which we really need to look into and ask them to reduce if they can.
And do you recommend any specific antioxidants or specific amounts?
No, as I was stating, and you can see this in the paper, we just use a very simple formula of omega-3, 1 gram a day, and Q10, 100 milligram a day, and then just the multivitamin. But the exact contents of the multivitamin can be seen in the paper which is published. So this is actually very, very simple and cheap also. Because we all have to realize there's a huge market out there for antioxidant treatment and be daddy and be mommy, etc. And I think some of our patients are being misled and are paying huge amounts of money for something which they could get at a lower cost.
Yes. And with abstinence period, would you recommend for the semen sample on the egg collection day, what abstinence period would be your recommendation?
Yeah, I was just discussing this with Sheena. So since 1.5 years back, we actually changed our abstinence period. Obviously, we needed to do a study on this, but we changed our abstinence period. So all males are recommended to have an ejaculate the day before the pickup. So we reduced it to 1 day, 24 hours.
And have you seen a change in success rates from?
Well, again, we did, and this is obviously always a problem. You read some papers, you do a change, and what we should have done, obviously, was still possible. You could compare the DNA fragmentation if you change to 24 hours, and then obviously you should correlate this to the reproductive outcomes. But you would need a multicentric trial to do this to get some real large data. But this is a good idea for a multicentric trial.
What level of DNA fragmentation would you say is where you would start to treat it?
Yeah, I think this is a very good question, and the discussion is still ongoing. But in the analysis, the paper, the review paper, which Sandra Steves was the principal author of, I think there's a very nice correlation between the 4 tests that we were discussing, the SCD, the SCASA, the COMET assay, and the Channel assay, that the cutoff is around 20%. And this is where we start considering lifestyle intervention.
Do you have any preference for any of those methods? Which would you say was the best?
No, I think it's, for us, we started with SCASA because SCASA was the first method available in the Nordic in one place in Copenhagen, and it's still there. It then spread to Malmö. So I think we have got these 2 centers, or these 2 places, one professional lab and one lab in a university. So this was actually more or less just a coincidence that we started with the SCASA, and we're now also trying out the COMET assay.
How do you think we could persuade more fertility clinics to test everyone for sperm DNA fragmentation?
Yeah, I think it's like everything else in ART, probably like in science. It usually takes you 10 years to convince colleagues about a new methodology, and this is for everything. This is for stimulation, this is for trigger. I tried it myself the hard way with ovulation trigger, agonist trigger, etc. In the beginning, people will say this is worthless. After 5 years, well, it might help. After 10 years, people are going to say, well, this is what we always did. So there's a huge degree of conservatism, and the only way to get it out there is to have seminars like this and to spread the rumor. And then hopefully some of our colleagues are going to look into some of these patients who have repeated failure and start thinking, not just treating the lady, but saying, okay, let's have a DFI. I can give you a wonderful example of this, because you just need 2 or 3 positive anecdotes for yourself as a clinician to say, well, obviously the honest way is to go to dig a little bit deeper to see what's going on. So we had this couple some years ago, it's 3 years ago now, and she had endometriosis, she had tubal factors, and we were treating her and we were doing everything. She was operated, etc., etc. We were transferring excellent blastocysts 3 times, single embryo transfer, and every time either biochemical or early pregnancy loss. And she still had 3 blastocysts in the freezer. So I decided, and this was before we started studying, I just thought we need to convince this couple to pay, because they still need to pay out of research. They still need to pay in Denmark for this specific analysis, and it's quite costly. You could say it's around $500 US. So I said, listen, you've got 3 blastocysts in the freezer, but I feel that we should do something about this. He did the DNA testing, that his DFI was 35. He did a 3-month lifestyle intervention. We checked it later on. It was 18. We did a new stimulation, had 3 blastocysts in the freezer. She conceived, had a live birth with blastocyst number 1, and she came back 1.5 years later. 1.5 years ago for blastocyst number 2, and she's now got two kids and a third possibly waiting in the freezer. This is just anecdotal, but I have so many of these kind of stories, and I think this is the same with my colleagues. You just need to try it a couple of times to see the benefit, and you will understand that obviously we cannot just go around with a test which is from 1916. We need to dig deeper.
I think we've got time for one last question. So when it comes to DNA fragmentation and ART, it seems to make most sense to try to identify the least damaged sperm. Have there been any studies confirming DNA level using Comet tests on Zymot or any other sorting devices?
I'm not aware of this. I'm not aware of this, but obviously there are these new microfluidity tests which we didn't have in our lab. I haven't tried it, but there will be new selection methods which probably will reduce the risk of DNA damage.
I think I'm going to hand over to Eileen at this point. We have just about run out of question time.
Yeah, so thank you, everyone. Let me just quickly share my screen again. So thank you very much to our chairs, and also, of course, thank you very much to Professor Humaidan for all of your time and for the many questions that you've asked as well. So we will, if you've other questions to ask, please do feel free to contact us, and we'll be happy to come back to you on those. So just as a reminder, coming up, we have our next webinar is Professor Andrea Salonia, who'll be talking about, is infection a common cause of male infertility, which takes place on Tuesday, the 30th of November, at the same time at 6 p.m. Well, BST, sorry, it's GMT now. Correction with the clocks going back at the weekend. So this will be our final event for 2021, where we're joined by Professor Andrea Salonia, Professor of Urology at the University Vita Salute in San Raffaele in Italy. So if you haven't already registered, you can do so online at the Examen, on the Examen website. So it just leaves us to say thank you again. Thank you for joining. Thank you for the wonderful talk by Professor Humaidan. I'm sure you all enjoyed it very much. And please don't hesitate to get in touch to find out more about our webinars and our tests. So thank you, everyone. Enjoy the rest of your evening.
Thank you, everyone. Thank you, and good night.
Thanks. Good.